Hello, and welcome to the CAP Today webinar for Wednesday, March 30th. I'm Bob McGonnagle, the publisher of CAP Today, and as usual, I'll be your host and moderate a question and answer session after our formal presentation today. Today's webinar is entitled Enabling In-House Comprehensive Genomic Profiling for Today's and Tomorrow's Clinical Needs. This webinar is made possible by a special educational grant from Illumina, and we are very grateful for their support and want to acknowledge Illumina for their essential help in enabling us to bring you this important program. Today we have a single speaker, Dr. James Solomon of Weill Cornell Medicine in New York. I'll say more about him in due course when I introduce him to begin. But first, of course, I want to go through some housekeeping items with you. We often suggest that you refresh your browser. We have live help available at all times. You'll see in the bottom right-hand corner of your screen. You can call that toll-free number for support, 858-345-5916. Live operators are available to help you. Also, you'll see a question and answer box that's below the slide deck. You can make any kind of a technical question or comment there if you're having a technical problem. But of course, the Q&A is available for you throughout today's webinar to make comments, to ask questions of our speaker, and as I said at the end of his talk, we'll open things up for a question and answer session. So type those questions and comments as they occur to you, and we'll get to all of them that we can. I want you to know that we'll have the audio and slides fully available for you at captodayonline.com in about 5 days. You'll see perhaps some follow-up email from us, and I want to assure you that it's all legit, so you may expect that. And finally, as always, I need to note that CAP Today does not endorse any product or services that may be mentioned today. Also, any comments that I make are purely personal and obviously not to be taken as policy of the CAP Today or the College of American Pathologists. So now we can turn and begin our real program here. As I said, Dr. James Solomon is the medical director of the Clinical Genomics Laboratory and assistant professor of pathology and laboratory medicine at Weill Cornell Medicine in New York City. He's a product of the University of California at San Diego, receiving his PhD and medical degree there and completing his AP and CP residency in pathology at San Diego. He then went to New York, but to Memorial Sloan Kettering, where he completed 2 fellowships, one in surgical pathology and one in molecular pathology. And in 2019, he came to Cornell Medicine, where he is today, and he's going to lecture on comprehensive genomic profiling. Now, I want you to note, we pre-recorded Dr. Solomon's lecture about a week ago. We did this for time and did it for accuracy, and we're very pleased with the results. After we've listened to this recorded lecture and slides, he's going to join us live for the question and answer session, so stay tuned and type your comments and questions throughout today's presentation that you're just about to hear. So now I will ask Dr. Solomon to begin, and we'll share his lecture with you now. Thank you.
Thank you very much for that introduction. My name is James Solomon, and I am the medical director of the Clinical Genomics Laboratory at Weill Cornell Medicine. Our laboratory focuses on next-generation sequencing of solid tumors, and so I will be talking about our experience and how in-house comprehensive molecular profiling can be performed to meet today's and tomorrow's clinical needs. So these views are my own, and I'm not being paid by Illumina. So precision medicine is fast becoming standard of care in oncology. In the past, every patient with a certain disease was offered the same treatment: surgery, chemotherapy, radiation. But today, testing is often performed to precisely characterize tumors. This allows patients to be subdivided into subpopulations that are amenable to very specific treatments, such as targeted therapy that focuses on specific alterations, immunotherapy that can recruit the patient's own immune system to fight tumors, or even use the patient's own genetics to synergize with certain systemic chemotherapy. And this is probably best illustrated by lung cancer. In the early 20th century, non-small cell lung cancer was essentially just one disease. Later on in the 20th century, treatment started to be tailored to patients based on histologic subtypes, squamous versus adenocarcinoma. And then in the early 2000s, everything changed when molecular subtypes were identified, and certain treatments, such as EGFR TKIs, were found to be more effective in patients with EGFR mutations. And as we learn more about additional oncogenic drivers, this portion of the pie that is labeled as unknown is shrinking. So we're identifying many new oncogenic drivers to learn more about lung cancer. So the diagnosis of cancer first begins with the surgical pathologist rendering the pathologic diagnosis, stage, and the grade of the tumor. And surgical pathology is never going to go away. There's tons of information, gigabytes of information on every slide that is interpreted and integrated by the surgical pathologist. In addition, in the surgical pathology lab, this is also where precision medicine begins. The surgical pathologist can apply immunohistochemistry or other ancillary studies to aid in the diagnosis, characterize certain biomarkers such as ER, PR, and HER2 in breast cancer, and quickly identify certain critical molecular alterations, such as using the D5F3 antibody for ALK fusion determination. There are antibodies for IDH1 mutations or P53 expression. After surgical pathology characterization, this is when the molecular pathology laboratory comes in to provide additional, more comprehensive information about the molecular drivers behind the tumor. And this information can be very helpful to fine-tune the prognosis and inform treatment decisions. And in many cases, it may make a patient eligible or not eligible for certain targeted treatments or clinical trials. So what we do in the molecular pathology lab is DNA sequencing to identify mutations in oncogenes, tumor suppressor genes. We can do DNA sequencing to identify copy number changes that can be oncogenic drivers. We perform RNA sequencing to identify oncogenic fusions and splice variant transcripts. And then there are many emerging and already emerged molecular biomarkers, such as tumor mutation burden and microsatellite instability. And all of these, again, inform treatment decisions and prognosis and may make patients eligible for certain targeted treatments or clinical trials. And so while tumor characterization is the goal of any molecular pathology laboratory that's performing testing on solid tumors, assays can vary widely, and a number of considerations must be addressed when making a decision of how to perform comprehensive genomic profiling. So these questions include, how comprehensive should an assay be? Should it be focused on just the most pertinent genes with demonstrated clinical utility, or should it be more comprehensive to provide more information? Other considerations include how easy it is for it to validate and implement an assay. What is the limit of detection of that assay? Turnaround time is a very important consideration. And turnaround time includes not just the time that it takes to perform the assay and the sequencing and the analysis, but also the batching samples up front to fill an entire run. And then also the interpretation on the back end should also be considered. The volume of testing that can be expected, how labor-intensive an assay, the associated cost, reagents cost, and capital costs. And then reimbursements are also an important consideration. One thing that we've been finding recently in our lab is that reimbursement can vary widely based not only on insurance, but also the area of the country that the practice is in. Different Medicare regions can have different priorities for reimbursement. And then finally, an important consideration is whether or not an assay can have the potential to provide clinical and translational research applications for academic clinicians and or provide testing for clinical trials. So with these considerations in mind, there are a number of specific attributes of an assay that can sort of affect these considerations. Some of these attributes include the library preparation, whether it's Ampliconbased or hybridization capture-based, the type of sequencing technology used, the bioinformatics and analysis pipeline, or how results are interpreted by the pathologist and reported. And so to highlight these considerations and to put them into context, I will describe the comprehensive genomic profiling assay that we've performed here at Weill Cornell. It's a rather comprehensive assay covering the entire coding region of over 500 genes, identifying single nucleotide variants, insertions and deletions, and copy number variants. It reports molecular biomarkers, microsatellite instability, and tumor mutation burden. It also incorporates RNA sequencing for the detection of oncogenic fusions and splice variant transcripts in genes such as MET and EGFR. And it uses hybridization capture-based sequencing for accurate detection of fusions in a fusion partner agnostic way. And it incorporates unique molecular identifiers for error suppression. So one of the first things to consider is the method of library preparation. We can't just put our extracted genomic DNA directly into the sequencer because there's a lot of real estate that we're not interested in. Most of what we're interested in is the coding regions of the cancer-related genes. And so we have to prepare a sequencing library. And one of the methods to do this is Ampliconbased library preparation. And so Ampliconbased is essentially a series of PCR reactions. A pool of PCR primers is added that flank the regions of interest, and each of these regions is then amplified to enrich the library for the cancer-related genes. And after cleanup, this library is what's sequenced. The software then aligns these to the reference human genome for analysis. And so here on the right side of the slide, we can see a screenshot of IGV, the Integrated Genomics Viewer, which shows the reads aligning to exon 19 of EGFR. And you can see that approximately 20% of these reads have a deletion here as designated by the horizontal line. And this is a 15 base pair in-frame deletion in exon 19 and is amenable to targeted therapy with EGFR TKIs. One thing you might notice about this IGV screenshot is that a lot of the reads start and stop at the same point. And this is because this is where the PCR primers sit. They flank this region. And so it can be difficult to tell whether each read represents a unique DNA molecule or whether we are sequencing PCR replicates of the same DNA molecule and getting multiples in the same read. In hybridization capture-based sequencing, the extracted genomic DNA is first, the extracted genomic DNA is then fragmented, often by sonication, and then it undergoes end repair and adapter ligation. And we end up with this pool of DNA fragments, some of which we want to sequence and some of which we don't. The ones we want to sequence are represented by the colors here. These represent the DNA from cancer-related genes. And so in order to isolate these, probes are added that are complementary to the regions of interest. These probes hybridize with the fragments that we want to sequence, and the probes have magnetic beads attached that can be captured. The rest of the fragments are washed away, and then after cleanup, we have our enriched library that can be sequenced. In contrast to amplicon-based sequencing, hybridization capture libraries, when aligned to the reference genome, you end up with a normal distribution of coverage that surrounds the hybridization capture probes. And this enables you to identify unique individual DNA molecules versus PCR replicates. In some assays, such as the one that we use, there are also unique molecular barcodes that can be added in the adapter ligation step to further distinguish unique molecules from PCR replicates. This table also summarizes the two library preparation methods. So amplicon-based methods are more suited for smaller panels because as they increase in size, more separate wells of different PCR reactions must be performed to keep the primers from interfering with each other. Hybridization capture methods, on the other hand, can be used for panels of any size. Hybridization capture is more complex, reagents are often more expensive, and it's generally more labor intensive, so turnaround time is often longer. However, in general, they're more accurate than amplicon-based sequencing. And lastly, I'll get more into this later, but oncogenic fusions can be detected in a fusion partner agnostic way, whereas with amplicon-based methods, both fusion partners must be covered by the assay. So implementation of the comprehensive genomic profiling panel is another important consideration. How difficult is it to get it up and running and validated? So one can spend a lot of time and effort designing and customizing, custom hybridization capture probes or PCR primers and tailoring bioinformatic pipelines if you want to create a panel yourself. But there are today there's a lot of prepackaged commercial kits available, and this is actually what we use. We use an end-to-end oncology assay just because it's so much easier to implement and validate. Our assay uses prepackaged kits for library preparation. It comes with a bioinformatic pipeline already pre-configured and prepackaged, so minimal bioinformatics support is needed. It's essentially just plug and play. And it comes with reporting software that's supplied by a third party, PurionDX. And the whole thing integrates with our hospital LIS very smoothly. So I'll talk a little bit more about some of these. One of the biggest challenges that many laboratories face is bioinformatics. And leveraging a commercial solution that has been thoroughly tested and validated and is supported by a vendor is extremely valuable. So the pipeline that we're using includes quality metrics to assess the quality of the sample and the quality of sequencing. And the full pipeline is fully vetted, from the FASTQ generation to variant calling, including copy number variants, microsatellite instability testing, tumor mutation burden calculations, and RNA sequencing pipeline. There is a good amount of upfront implementation that does require information technology support and resources to set up, but no customization or adjustment of the actual pipeline is required. Our assay also leverages the third-party reporting solution, which is the clinical genomics viewer that's powered by PurionDX. This interface allows the pathologist to review all of the variants that are detected by the assay. You can select whether to report them or not using these switches that are on the left side. You can change the tiers under that classification column, and you can adjust interpretations. This reviewing solution also comes with a crowdsourced knowledge base to describe variants, and these interpretations can be edited and customized for individual reports. Our assay is also fully integrated into our laboratory information management system. So we use Cerner COPATH and exemplar LIMS. Cases are accessioned in COPATH, and the data automatically transfers to LIMS, and the metadata also goes to the PurionDX reporting software. Exemplar LIMS is used in the laboratory to track samples. Laboratory workflows are run to follow the library preparation in the lab. And LIMS also captures a lot of the intermediate data, such as the library concentration and other quality metrics. The LIMS also automatically generates a sample sheet that's then used by the sequencer. So sequencing is then performed. Data is transferred to an analytical storage via an ingestion server, and then the analysis pipeline is run. The analysis pipeline is run, and the analyzed data is then sent to PurionDX for review by the pathologist. The pathologist signs out the case, and the report goes back to COPATH, where it's signed out and then eventually gets back to the patient's medical record. So overall, the process of implementing the assay and running it is quite straightforward. The next step is therefore the validation of the assay. So commercial products need to undergo a very rigorous validation in the clinical lab, but especially so in New York State where we operate. The New York State Clinical Laboratory Evaluation Program oversees all laboratory testing for New York State patients. And so our validation is needed to satisfy their requirements. I'll give a high-level overview of some of the example experiments that we did. I'll high-level overview here, but this is not completely comprehensive. The first thing that we needed to do was the analysis of a few well-characterized cell lines. So we evaluated 3 separate cell lines with known SNPs and indels at heterozygous or homozygous variant allele frequencies, and we compared these known values to our sequencing results. And so we see there's the 3 separate cell lines, and it was 90% sensitive for SNVs, 100% specific for SNVs, and for indels, it was in the 90% sensitive for indels, and 100% sensitive for 100% specific for indels as well. We also performed limit of detection results. So we sequenced serial dilutions of commercially available standards. Examples here shown here are BRAF V600E and JAK2 V617F. So these are serial dilutions of a commercially available sample, and we can see that it's able to detect down to about 1% in these commercially available samples. We also performed sensitivity experiments in FFPE samples that are derived from patients, shown here in the table on the left. And so based on our analysis, we determined the analytical sensitivity of this assay to be about 3% at 350x coverage. We also examined reproducibility across runs. Here we show Levy-Jennings curves highlighting the consistency across different runs. All of them showed very good consistency. I will highlight EGFR T790M, which was not detected in 2 runs because the expected variant allele frequency was below the limit of detection, so twice it was not detected. Otherwise, everything was very reproducible. And then also these Levy-Jennings plots are highlighting inter-run reproducibility, but please note that intra-run, running the same sample multiple times on the same run, also needs to be performed for the validation. Finally, probably the largest endeavor is demonstrating accuracy, showing that the variants detected by the assay being validated are approximately the same as an orthogonal method. And here we show the correlation of variant allele frequency for single nucleotide variants on the left and indels on the right. This graph also shows the correlation of copy number calls with our assay compared to an orthogonal method. And so we submitted to New York State, and after their approval, the whole assay was able to go live for clinical testing. And so with the remaining time, I just wanted to highlight a couple of specific applications of comprehensive genomic profiling: calculation of tumor mutation burden and identification of oncogenic fusions, 2 extremely relevant topics in today's oncology practice. So immune checkpoint blockade targeting PD-1 and PD-L1 has revolutionized cancer therapy. Normally, PD-1 binding to PD-L1 inhibits T cells from responding and attacking the body's own cells. But inhibiting this interaction can help to activate these T cells and make them better suited to fight cancer cells. The more mutations in a cancer cell, the less it looks like a normal cell to the immune system, and the more neoantigens that the immune system can recognize. Pembrolizumab, an anti-PD-1 inhibitor, can be used in MSI or MMR-deficient tumors, which often have a lot of mutations. This is a tumor type agnostic biomarker, and MMR status or MSI status can be evaluated by IHC, PCR methods, or next generation sequencing. But recently, pembrolizumab was also approved as monotherapy for the treatment of adult and pediatric patients with unresectable or metastatic solid tumors with high tumor mutation burden scores, a TMB defined as greater than 10 mutations per megabase as determined by the Foundation-1 CDX assay. And this is based on objective response data from 102 patients across 9 different cancer types. And so while Foundation-1 CDX assay has demonstrated clinical utility and is associated with pembrolizumab use, there are a number of ways of determining TMB. Using whole exome sequencing is considered the gold standard, but this is not always feasible within the clinical lab. Whole exome sequencing requires matched tumor normal sequencing, and then even if you're able to perform that, the bioinformatic pipelines are not always standardized from one whole exome sequencing assay to another. Additionally, the specific algorithms for calling and calculating tumor mutation burden can vary. One example is whether or not to include oncogenic driver alterations and what exactly constitutes an oncogenic driver. Cancer gene panels, if large enough in size, can be leveraged to calculate tumor mutation burden, as well as whole exome sequencing. There's a recent paper published in February in the Journal of Molecular Diagnostics that compared the comprehensive genomic profiling assay, the same one that we use at Weill Cornell. It compared it with both Foundation-1 CDX and whole exome sequencing. This is just showing the exact correlation of the tumor mutation burden among the 2 assays. And as you can see, the correlation is decent, especially at the high tumor mutation burden end. It varies a little bit as you get to lower tumor mutation burden. But more important than the actual number is the binary calling of high tumor mutation burden versus low tumor mutation burden. And so for that analysis, comparing the binary calls of high versus low, the authors performed receiver operating characteristic curve analysis. And they compared the CGP assay with Foundation 1 CDX and with whole exome sequencing. Comparing with Foundation 1 CDX demonstrated very good area under the curve, and they showed that a cutoff of 10 is also the best cutoff for maximizing sensitivity and specificity as compared with Foundation 1 CDX. The area under the curve was not as high for whole exome sequencing, but when compared with the Foundation 1 CDX, it was approximately the same. So both Foundation 1 and the assay that we're using had approximately the same area under the curve as compared to whole exome sequencing. However, the most important thing is correlation with clinical outcome. This chart shows the overall response rate to immunotherapy. Patients with high tumor mutation burden are shown in dark green, and they had a better response than the patients with low tumor mutation burden, shown in light green. The CGP assay that we used was able to stratify these patients very similarly to Foundation 1 CDX, as shown in the graph on the chart on the left, and as compared to whole exome sequencing, as shown on the right. So it seems like TMB is able to effectively stratify patients in many circumstances, and it seems like a great universal biomarker. However, it does have some caveats. This recent study in Annals of Oncology was a meta-analysis looking at tumor mutation burden in a number of different studies. One particular characteristic that they examined was CD8 T-cell infiltration and how it correlates with neoantigen load. As I mentioned previously, one thought is that tumors with high mutation burden look less like a patient's self, and therefore the immune system and CD8 cytotoxic T cells are more likely to respond to that cancer cell. This is indeed the case with certain tumors. So here in uterine corpus endometrioid adenocarcinoma in the upper right, you can see that there is a good correlation of neoantigen load with CD8 T cell score. As neoantigen load increases, so too does the CD8 T cell score. This also occurs in lung adenocarcinoma, bladder cancer, and colorectal adenocarcinoma, and these are categorized as these category 1 tumors, where CD8 positively correlates with neoantigens. Many other tumors, such as the prostate cancer, shown in the bottom right, do not correlate as well. There's essentially no correlation between the neoantigen load and the CD8 T cell score. And a lot of these tumors were then categorized as category 2, where CD8 does not correlate with neoantigen score. And so the authors found that tumor mutation burden predicts the response to immune checkpoint blockade only in those category 1 tumors, those where the neoantigen load correlates with CD8 T cell levels. So here in endometrioid adenocarcinoma, chart A, patients had a much better response if they were high tumor mutation burden than if they were low tumor mutation burden. Same with melanoma, bladder cancer, and non-small cell lung cancer. However, in the category 2 tumors, those where neoantigen load did not correlate with CD8 T cell levels, there was essentially no difference in patients' response. In this prostate cancer trial on the right here, letter K, patients with low tumor mutation burden responded at about the same level as patients with high tumor mutation burden when they were given immunotherapy. And so therefore the authors concluded that while tumor mutation burden demonstrates promise as a predictive biomarker for patient selection for immune checkpoint inhibitor treatment, our analysis fails to support the hypothesis that a single tumor mutation burden threshold can identify patients in a pan-cancer fashion who may benefit from immune checkpoint inhibitor therapy. If there was a correlation between CD8 T cell infiltration and tumor mutation burden, then tumor mutation burden high patients showed improved response to immunotherapy. And if there was no correlation between neoantigen load and CD8 T cell infiltration, such as in breast and prostate cancers, then tumor mutation burden high patients showed essentially no improved response to immunotherapy. And so what do we do here at Weill Cornell? Well, we still use the tumor mutation burden threshold of 10 because that is what is most described in the literature and how pembrolizumab is FDA approved. However, we also find that it's also important to include a disclaimer. So we describe how we call TMB, how it's calculated, and what threshold we're using. And then we include this disclaimer that says, please note that this threshold was determined for selected tumor types per FDA guideline, and its applicability to all tumor types is not known at this time. The tumor mutation burden is definitely a promising biomarker, but it has its caveats. So I wanted to shift gears now to oncogenic fusion detection in solid tumors. So gene fusions have been recognized as oncogenic drivers for decades now. And one of the classic examples is the 922 translocation as seen in chronic myelogenous leukemia. It leads to the Philadelphia chromosome and the BCR-ABL chimeric protein. And this protein gains constitutive activity of the ABL tyrosine kinase and results in downstream activation of the JAK-STAT, MAP kinase, and other pathways that lead to tumorigenesis. So with the advances in sequencing technology, and as we discover more about pathology in general, oncogenic fusions are also being increasingly recognized in solid tumors. The fusions in solid tumors result in a translated chimeric protein that is constitutively active. It's often a tyrosine kinase, and it activates downstream signaling pathways. The detection of oncogenic fusions is important for a number of reasons. First, some fusions are characteristic or diagnostic of certain pathologic entities. On the left is a circus plot showing many fusions seen in sarcoma, many of which define the pathologic entity. In addition, in many cases, especially in carcinomas, there are targeted therapies. And so on the right here, we have a crystal structure of a ROS1 inhibitor that's binding to the tyrosine kinase domain, and I think is a good example of how these fusions are targetable. So this is just a partial list of the targeted therapies that are associated with oncogenic fusions or splice site variants. Many of them are indicated in non-small cell lung cancer, but there are increasing numbers of basket trials where drugs are not directed towards a particular histologic so they're not targeted towards a particular histologic subtype of tumor, but they're instead targeted on specific molecular alterations. And the NTRK fusions are a great example of a successful basket trial for which larotrectinib and entrectinib are now FDA approved. There are a number of methods for detection of oncogenic fusions. So FISH has often been called the gold standard for identification of translocations. It's a DNA-based assay that can be used to assess for structural variants in formalin-fixed paraffin-embedded tissue. For detection of fusion, there are two main types of probes. There's break-apart probes and dual-colored dual fusion probes. In the fusion probes, the normal signals are separate, but when a fusion occurs, these two signals come together to demonstrate the presence of a fusion. And this is an example here on the left of an LMNA NTRK fusion. So in the background lymphocytes, you can see that the green signals are separate from the red signals, but in the spindle-shaped cells, these two signals have come together, and the LMNA and the NTRK are fused to form this chimeric protein. In break-apart probes, in contrast, the red signal is break-apart probes in the normal signal, the red signal is on one side of a gene and the green signal is on the other side of the gene. So a normal signal is a fused signal. And then if a translocation occurs at that break point, those two signals will separate. And so you can see an aberrant signal of the red signal being separate from the green signal. So FISH has a number of advantages. It's very sensitive, especially in samples with low tumor content. It has a fast turnaround time and only requires a few unstained slides. But the drawbacks are that it's very low throughput. You have to have separate FISH probes for every fusion that you want to identify. And it can occasionally miss fusions if there are non-canonical breakpoints or fusion partners. A number of immunohistochemical antibodies have also been developed for a number of fusions. Some of the antibodies are very effective, such as the ALK-D5F3 antibody shown here. And if the antibodies are available, they have a number of advantages. They're very fast, since they can be examined by the surgical pathologist at the time of surgical diagnosis. And immunohistochemistry is widely available in many surgical pathology labs. But like FISH, they're very low throughput. A different antibody is required for every fusion that is screened for. And many antibodies are not actually as good as the ALK antibody. NCCN guidelines say that the ALK antibody can be used as a standalone test and does not require confirmation, but there's no other antibodies like that. ROS1 and NTRK antibodies are not as sensitive or specific. RNA-based sequencing of the expressed RNA transcripts is becoming much more widely used for comprehensive fusion detection, and it's starting to replace FISH as the gold standard for fusion detection. It has a number of advantages over the other two methods. It's high throughput, it can assess for multiple fusions and breakpoints at once, and it provides evidence of functional transcription. The chimeric RNA can be definitively identified, so you can be sure that it's being transcribed. Some drawbacks of RNA-based sequencing is that RNA can be a little bit difficult to work with. It's labile, requires specialized reagents, equipment, and expertise, and it can become degraded, especially as samples age. So if samples are stored for a long time and you want to go back to an old FFPE sample, the RNA is often degraded. Therefore, it's important to implement adequate quality control measures to assess the amount and quality of RNA that's obtained. It's also important to note that RNA sequencing is not all the same. There are a number of different chemistries that can be used to sequence RNA, and it's important to understand the limitations of certain panels. One widely used chemistry is, as we discussed, Ampliconbased sequencing. So in this method, RNA is converted to cDNA, and then a PCR primer for each fusion partner is required to amplify up any potential chimeric transcripts, which are then sequenced. And so for this reason, each fusion partner must be known because you need a primer to sit down on each fusion partner. In hybridization capture chemistry, RNA is again converted to cDNA, and hybridization capture probes that are complementary to the gene of interest are added. The probes contain magnetic beads that can then be isolated and pull down any fragment that they would hybridize to, including any chimeric transcripts. So then when these are sequenced, the partner gene can be identified. In anchored multiplex PCR, RNA is converted to cDNA and adapters are ligated to the ends. These adapters contain a universal PCR primer site in green, in this figure. A PCR reaction then occurs with the universal primer and a gene-specific primer. A second nested PCR reaction is then performed to increase specificity. So the library is then sequenced, and again, any chimeric transcripts can be identified. Both hybridization capture and anchored multiplex PCR methods are both fusion partner agnostic. So rare fusions and novel fusions can still be detected. Amplicon-based panels may miss some of these novel fusions. So as I mentioned earlier, the comprehensive genomic panel that we use here at Weill Cornell uses hybridization capture technology, which is one of the fusion partner agnostic methods. And so additionally, it's important to note that the bioinformatic analysis of the RNA sequencing is already packaged and easy to implement. So in conclusion, I hope I've effectively described our experience with our comprehensive genomic profiling assay here at Weill Cornell. We leverage a commercially available end-to-end oncology assay that is supported by the vendor and third-party software. It contains a preset bioinformatic workflow that requires no customization and only minimal IT support for maintaining the pipeline. And the reporting software makes it for easy interpretation and report generation. It integrates with our laboratory information system, and all of this really makes it a great comprehensive genomic profiling solution. I also showed how it effectively calculates tumor mutation burden, and it's functionally similar to the Foundation-1 CDX assay. And it uses hybridization capture technology for fusion partner agnostic oncogenic fusion detection. So with that, I thank you very much for your attention, and I am happy to answer any questions.
Dr. Solomon, thank you very much, and we'll get you now on the telephone. We'll put on our lobby slides for the question and answer session. Let me remind you once again that you may, in the question and answer box, make comments, ask questions, and I think we'll have ample time to get through most of those. Let me begin just for to clarify, Dr. Solomon, I assume you're on now?
Yes, hello everybody.
Yes, thank you so much. That was a wonderful, wonderful talk and very rich in content, so I know people will want to review it in a few days at captodayonline.com. Let me just ask you to clarify, because we had an early question. Is it possible to adapt Amplicon-based methods to capture fusion events in an agnostic manner?
Yeah, that's a good question. So I'm not familiar with a way to adapt an Ampliconbased method. So traditional Ampliconbased methods, they require as I had shown in that one figure, they require primers to basically sit down flanking the chimeric transcripts. So you basically need one primer for each fusion transcript to get that amplicon. So for example, for like ETV6 and NTRK3, you need one primer for the ETV6 and one primer for NTRK3. And if there is a fusion that occurs, you will get the amplicon that shows that chimeric transcript. There are some other chemistries, though, that can sort of get around that and still sort of use, PCR Amplicon-based methods. And so probably the most widespread one in use is the anchored multiplex PCR, and that's made by Archer, the Archer platform. So for that one, you have your transcripts, and then they add adapters to each side of the transcripts. And so this allows for one primer site to be a universal primer that can sit down in that adapter site. So you basically just need one gene-specific primer and one primer that then sits in this that sits on the universal site in the adapter, and you can create your library that way. So that would be, I guess it's sort of an Amplicon-based method for fusion partner agnostic detection.
Thank you. Thank you very much. Our next question is as follows. In the validation of next-gen sequencing, what did you use for orthogonal as an orthogonal method for the validation studies?
Oh yeah. We actually used a variety of methods, and that was fine with New York State. Probably most of our cases, we also have a smaller Amplicon-based panel that we use. So probably 80-90% of the cases had been previously run on the smaller Amplicon-based panel. But in some cases, we either didn't have extra material or for one reason or another, so we had other panels. Some cases had been sent out to Foundation 1. Some cases had whole exome sequencing done in the research setting. Some cases even had single gene assays done with digital droplet PCR or something. So yeah, it was a variety. New York State has pretty strict guidelines on the numbers of cases and the distribution of FFPE versus fresh samples and everything. But as long as it's a robust orthogonal panel, they're generally okay with it. Obviously, a clinically validated live NGS assay for your orthogonal panel is ideal, but it's not absolutely necessary, and it's not always possible to do that. So, I'm not saying anything can be used, but there are a number of options that can be for an orthogonal method.
Thank you very much. Our next question again involves a validation question. Could you describe your approach to the validation for gene amplification and CNV calling using your assay? Do you apply a general cutoff, or do you have gene-specific cutoffs?
Yeah, that's a good question. So, in general, for CNV calling, we mostly use that first other NGS panel that I had mentioned. So, and in this particular case, for this assay, it's a general cutoff. Basically, if it is greater than twofold difference, it can be called, and that basically was our limit of detection. So if it was at least a twofold difference, we were able to definitively identify it as being amplified. If it was less than that, it's sometimes blended in with the noise. That is a very good point, though, about gene-specific cutoffs could potentially be used. For this particular assay, the bioinformatics was super robust, and sort of everything was created and validated by Illumina. So, it was we could basically just validate it and make sure that it worked correctly in our clinical lab. But yeah, if designing an assay from scratch, there can be differences in coverage of different genes. GC-rich areas or other things can affect coverage, and so gene-specific cutoffs might be necessary in those situations. But for a lot of the commercial solutions, I think a lot of that work has already been done, and so we didn't really need to do it in our clinical lab.
Thank you very much. Now, we've managed to precipitate several questions, all really asking the same question. So I'm going to try to summarize multiple questions here. Can you talk about how many actual samples you need to run for validation in your laboratory? Is there a rule of thumb, or is there a best practice for the number of runs you need to do to satisfy the precision requirement? And how many of those would be clinical samples used in validation?
Yeah, all very good questions, and that's always tough. So I would really recommend I'd recommend the New York State website. I think you can find it just by going to the the Clinical Laboratory Evaluation Program. Look for like laboratory developed tests, and they have really good guidelines for how to validate NGS assays specifically for oncology. So basically, to do an initial, they have a number of different levels of validation. For instance, so to do an initial validation, get your assay up and running, they require 50 samples, 50 samples like that have findings that you have an orthogonal method for, that you can show very good concordance. But at that stage, with just that initial validation, you still need to confirm basically anything you're reporting until you've done sort of a second level validation, a full validation. And full validation depends on what specific alterations you're looking for. So for single nucleotide variants, they basically say you need to identify 200 single nucleotide variants and have good concordance among 200 single nucleotide variants. For indels, it's also 200. For copy number variants, they require that you validate basically each gene that you're going to call amplifications in. For tumor mutation burden and microsatellite instability and some of the other biomarkers, they have other guidelines, and I think some of them vary from year to year. And from what I recall, I think we had to do 30 for microsatellite instability and about the same for tumor mutation burden. But the guidelines in general are very good. And I think there's been some publications too out by the Association for Molecular Pathology that give a good outline for how to validate a somatic NGS panel. So the short answer would be at least 50 samples, at least 200 variants.
Okay, thank you very much. Now here's a subject that's much in the news and everyone will be dealing with, but in particular for you, what is the sensitivity of CNV for HER2, and how do you deal with tumors with low HER2 amplification of just 3 or 4 copies?
Yeah. So sensitivity is also very dependent on tumor content. So tumors that have high sensitivity, tumors that have high tumor content, you'll be able to distinguish any amplification signal from noise. Tumors that are down around 10, 20, 30%, it's much more difficult to distinguish it from noise. We actually put in a disclaimer in our reports if the tumor is down below 30%, that the tumor content is low and copy numbers cannot be definitively called at that level. So particularly for HER2, if it's that low, honestly, I think FISH is still the gold standard for determining HER2 amplification. NGS is making some strides. There are ways of determining, there are ways of using some bioinformatics solutions to better estimate amplifications, especially if in matched tumor normal sequencing. But still, FISH seems to be pretty much the gold standard, especially for HER2. So hopefully that question.
That's a very good answer. Thank you. We have the following question. I'm sure it's on other people's minds as well as this individual. Do you match tumor and normal samples to rule out germline mutations? And if not, how do you distinguish the germline mutations from real oncogenic mutations?
Right. Yeah. So this platform is specifically designed for tumor only. So we do not do match sequencing. Obviously, match sequencing is it gives you the definitive answer of what is somatic versus germline, but it's more difficult to implement. It requires a blood draw, which is not always possible to get that from the patient. If they've had a surgery, they're away from the hospital by the time it gets sent for molecular testing. Sometimes the patient is no longer in the hospital, no longer present, and it requires a lot of coordination to get that blood draw. But this specific assay is designed to be very accurate in detecting the somatic or distinguishing somatic alterations from germline alterations, specifically for the TMB calculation. There's a number of proprietary algorithms that I don't quite understand all of the details about, but they use variant allele frequency and population databases to determine what is a somatic alteration and what can be called a somatic alteration for a tumor mutation burden calculation. But for calling things for SNVs or indels, the software that I demonstrated from Purion DX has a lot of that information, from population databases to the Cosmic database to tell you how often it's been seen as a somatic alteration, and so it's not too difficult to determine what are the somatic alterations versus what are the germline alterations. Now, there are always going to be some gray areas. There's going to be a few alterations where we might not really be able to tell. And so it's important to add those disclaimers in any report. We don't know if this particular alteration is somatic or germline, and so dedicated germline testing might be necessary. And so this comes up not infrequently, but in general, it's not too difficult to be able to tell the differences based on population frequencies and variant allele frequency and things.
Very good, thank you. Now, as you know very well, there are really two schools of thought around testing strategies in this space. Some lab directors prefer to have sequential tests to optimize turnaround time for some patients, and only use the comprehensive genomic profiling for negative patients. Others prefer to have one comprehensive test done for all patients. What's your opinion of these testing strategies, and how have the increasing number of important biomarkers affected your opinion and your testing strategies?
Yeah, I'm laughing to myself here because this is something we run into all the time. We're constantly having this discussion with our surgical pathologists and oncology colleagues. For some tumor types, turnaround time is super important. So with our thoracic oncology colleagues, they always want status, EGFR status, ALK status, KRAS status super quickly. They want to start the patient on immunotherapy if all those are negative. They want to start the patient on EGFR or ALK targeted therapy if positive. And given the course of that disease, they can't often wait a couple of weeks for the next generation sequencing results to come back. So that's on one side of the coin. On the other side, we have colleagues in neuropathology and gastrointestinal pathology that much prefer to just have the whole picture before starting treatment. And therefore they will, wait another week or two for the NGS results to come back to decide on a treatment strategy, given all of the information that this assay can provide, or other ancillary tests. So what we've done here is it's become sort of a complicated procedure where some cases go for our more quicker Ampliconbased, faster turnaround time assay. Some cases go straight for the more comprehensive hybridization capture-based assay. And in some cases, go for both because they want both fast turnaround time and more comprehensive. And so, that's what we're doing right now. We are continuously sort of refining that procedure, and it's been a little bit dynamic, but we're continuing to have discussions and trying to figure that out. But that is a very, very common question.
Very good. Thank you. Let me squeeze a couple more in here quickly. Is it possible to utilize the NGS data to develop a tumor of unknown origin function? In other words, the genomic prevalence score of a tumor of unknown origin.
So, like to determine what, like to give a possible source, to give a possible.
Yes, a possible primary. Right. Exactly.
Yeah. In general, I'm very cautious to suggest a primary site based on molecular findings. I've often found it to be more likely that a tumor has an unusual molecular finding versus a different primary or something like that. It's just very, very difficult to really definitively tell primary. You can certainly make suggestions, and there are certain things that are super specific. So a TMPRSS2 ERG, it's most likely prostate. It's probably not anything else. But NTRK fusions can be seen in anything. ALK fusions can be seen in anything. A lot of other findings, KRAS alterations, BRAF, a lot of other findings are not very specific for site of origin.
Very good. Thank you.
There are other, just very quickly, sorry, there are other methods that people use. So methylation profiling, I think, is probably an emerging technique where people will be able to identify cancer of unknown primary.
Thank you. Thank you for that. Let me just close with a couple of questions around tumor mutational burden. You present some very interesting data and now practice regarding your reporting of TMB. Is that gaining some greater understanding and utility in the minds of your treating physicians?
Yes, yeah. So the clinicians, the oncologists, have found that tumor mutation burden is super effective at determining which patients will respond to immunotherapy. There's been a lot of good studies looking at pembrolizumab based on tumor mutation burden. And so a lot of the oncologists really want tumor mutation burden, and in some cases they're running assay just for tumor mutation burden.
And is that actually helping you in dealing with your oncologists and also in case planning and tumor boards? These distinctions among the types of tumors that may benefit. Yeah.
I mean, it's. So we're constantly discussing patients that have people are often using that biomarker for treatment planning, and it's become pretty critical for some tumor types, especially the GI tumors. So they really need that it affects sort of what order they'll do their therapy in, and so it comes up all the time in tumor board and other discussions.
Well, thank you very much. And with that, I'll give you the last word. If you didn't see your comment or question asked, we will supply all of those for you, and we'll work with Illumina, and I'm sure Dr. Solomon would be glad to add some comments on questions that didn't get a chance to get asked. But I think now it's a good time to begin to wrap up. So this was a magnificent lecture, and it'll be available with the full audio and slides in about 5 days at captodayonline.com. I think you'll all wish to share this with colleagues and review yourselves because it's very rich in data. And I would like to then begin my thank yous. I want to thank Dr. James Solomon. He gave us a wonderful presentation today, and we're all deeply, deeply in his debt. I also want to thank Illumina for their sponsorship. We're very, very grateful for this kind of help so we can bring you these programs. And finally, I want to thank all of you. I know spring is coming, and we're even going to have some baseball soon, but you're all very busy. I know that extremely well, and I want to thank you for taking the time today to join us for this important CAP Today webinar. So once again, I want to thank Dr. James Solomon, I want to thank Illumina, and I want to thank all of you for joining us. And with that, I'll bring today's webinar to a close.